Obstetrics and Gynaecological Society. And on behalf of the Coimbatore Obstetrics and Gynaecological Society, it is indeed my extreme pleasure to invite all of you for this webinar, live webinar. Dr. Reena Abraham, who is the Secretary, Dr. Ramya, the Treasurer, Dr. Manohar Mani, the Vice President, and Dr. Baburani. So it's indeed a pleasure that we are having all of you here. And I would like to sincerely thank Mr. Subbu and Meenal for having helped us to have this webinar. If it were not for them, we would not have had this. Thank you so much. Now, this picture, I do not know how many of us would have had this opportunity to deliver such a baby. Now, this is a baby with hydropic fetalis due to erythroblastosis fetalis due to RH incompatibility. Now, in our postgraduate days, I'm sure one of the most important causes of bad obstetric history was RH negative pregnancies. But nowadays, hardly is it ever discussed in our forum. We don't see that many cases. That was simply because of Antenatal. I will tell her what happened. See, prior to 1970, the incidence of RH immunization was roughly around 10 to 15%. World over, the incidence of RH negative pregnancies is around 15%, 10 to 15% on average. In some countries, whereas in some countries like United States, the incidence is around 10 to 15%. Whereas in parts, the incidence is almost 100%. So they say on an average is around 10 to 15%. And all these individuals don't become alloimmunized. Only 10 to 15% of them are going to become alloimmunized. So what happened after 1970 was that once the Antibody was started, when people gave Antibody following delivery of these individuals, the incidence of alloimmunization came down drastically. And from 16%, it got reduced to around 2%. Subsequently, in various countries, they started this program, RADP, means routine antenatal administration of Antibody, and that brought down the incidence to around 0.2%. So now we all know that the incidence is in our country, maybe routine antenatal administration is not done everywhere, but however, the incidence is roughly around 2%. So the incidence is so less. So why this webinar? Simply because of two reasons. One is very low incidence. So when we see such a case, we should be able to know what is really happening, how we're going to manage this case. So it's necessary to update ourselves on this rare situation. And secondly, it is not only the anti-D which is causing this, but there are other conditions like CE, E, and KEL, which are also important in causing hemolytic disease of the newborn. So testing, antenatal care, and intrauterine interventions will help us to go a long way, and neonatal services. All this form the backbone of management of these conditions. So we should have a multidisciplinary approach, and for this, we have a galaxy of eminent speakers to go ahead with this panel discussion. First is we have Dr. Suresh, who is Director of Mediscan System. Sir, I welcome you heartily for having accepted our invitation. Thank you so much. He was a person who did the first IU Intrauterine transfusion. Dr. Prasanna Kumar, Dr. Nirmala Jayashankar, Obstetrician, Dr. Rohan Palshekar, Head of Bloom IVF Center at Pune, and Dr. Soumya, HOD and Consultant Neonatologist, GKNM Hospital. Welcome all of you all for this panel discussion. To moderate, so this panel discussion will be moderated by Dr. Sita Panikar. She is a professor of obstetrics and gynecology in our institution, PhD, Institute of Medical Sciences and Research, Coimbatore. She is a gold medalist, and she's honored as the Best Teacher Award by the Tamil Nadu MGR University. She's a teacher, PG teacher for almost 20 years. She's a much sought after PG teacher for all academic programs. If you have or Quest, wherever it is, Dr. Sita is always there. And in quotes, she's a knowledgeable teacher. So over to Dr. Sita Panikar.
Thank you, Dr. Chitra. Good afternoon, everybody. Welcome to this panel on red cell alloimmunisation, a condition where the previously dismal prognosis has been dramatically altered. But still, there's a lot of research and progress in many aspects of this condition. So it's my privilege to introduce our eminent panelists. We're extremely fortunate to have with us Dr. Suresh, Director of Mediscan Systems, Visiting Professor of Perinatology at SRMC and as well as PhD hospitals. So we are actually benefiting by his expertise. He's a pioneer in the field of intrauterine therapy. He established fetal medicine as a specialty in India. His many initiatives like the Fetal Care Research Foundation, Birth Defects Registry of India, and all, shows his commitment to the care of the unborn fetus. Mediscan Center acts as a referral center for intrauterine procedures from all over the country, even countries from Southeast Asia. And it's a much sought after training center for fetal medicine specialists from all over the world. Dr. Prasanna Kumar is a professor of pathology at PSG. She's been trained in hematopathology and transfusion medicine from the US. And she's our guru when it comes to difficult hematology or transfusion issues. Dr. Nirmala Jayashankar, consultant obstetrician and gynecologist from Apollo Hospitals, Chennai. She has an impressive list of educational credits, like she's won 6 gold medals in MD, which looks unbelievable. And we always looked upon her with awe when I was just 2 years behind her in MD. She's now known for her clear, practical, and logical clinical approach. And she asked me so many practical questions when I discussed this panel with her. She's a much sought after speaker at many national forums, and she's been selected as the vice president of OXI. Dr. Rohan Balchekar is the head of Unit Bloom IVF Center. He's an associate professor at the D.Y. Patel School of Medicine. He's an active member of MOGS and has held many executive positions. And he's a recipient of many awards, Foxy Corion, Shanti Yadav Award, as well as the Yuva Orator Award for 2020. Dr. Soumya is the head of pediatrics and in charge of the NICU at GKNM Hospital, which is known for its excellent neonatal care. She's currently the president of the IIP Coimbatore branch. So welcome all of you. So we'll go on to the discussion. Now, immune-mediated destruction of the fetal RBCs by maternal antibodies is a unique problem in obstetrics. It has a distinction of being one of the success stories where over the past 4 decades, the outcome has dramatically changed by the two-pronged approach, intrauterine transfusion, excuse me, as well as effective prophylaxis. And to deal with this complex problem, we need a multidisciplinary team, which is very typically exemplified by our panel. So let's discuss the various aspects of this complex problem by following a woman through her pregnancy. So she's a 30-year-old primary gravida seen at 12 weeks, the antenatal clinic. Routine investigation showed that she's Rh negative, and screening showed the presence of Rh antibodies. Now, what are the circumstances? This is not a typical scenario which we very commonly seen. So what are the circumstances in which Rh antibodies can be detected in the first pregnancy? Dr. Nirmala, would you like to take this question?
Good afternoon, Sita. Thank you for Sita and Chitra. I always get confused. And thank you for the invitation for making us to be.
Yes.
Am I audible?
Yes, I can hear you now.
Okay. Thank you, Sita and Chitra. And okay, normally in an Rh negative, a primary gravida doesn't get sensitized. The sensitization usually occurs after the delivery, but there are very rare circumstances where a primary gravida at 12 weeks, as early as 12 weeks, is sensitized. So when I get a report like this, first I will call the lab and check whether the report is correct, because I'm not expecting an antibody to be positive in a primary gravida. So first I'll check with the lab and see whether they have given me the correct report. And if they say yes, then what I would do is I will ask her whether in the past she has had any kind of transfusion. Because quite a few times they don't tell us, so you elicit the history. And in this, I would also like to mention that in dengue fever, you know, sometimes they transfuse platelets, so that could also be a reason for the antibodies being positive. And on a practical note, Sita, supposing I find a primary gravida being sensitized, I would kind of quietly call her and ask her whether she has not divulged any history of termination earlier, because it's not very common. But in clinical practice, no, they really do not want to tell us. So I would like to wonder why she got sensitized as early as 12 weeks, because we know that there has been an event in the past which has made her sensitized. So this is how I look at her.
Okay, thank you. Very practical. Dr. Rohan, would you like to add something?
In fact, that was one point which Nirmala ma'am said very well, that you must elicit any hidden histories that are there of MTP or any other abortion prior to the priming gravida. That's one practical point. What Nirmala ma'am has covered is very well. Then another thing, it could be maybe fetal-maternal hemorrhage, which may have occurred early as well in the first trimester. That could also possibly lead to, which may not have been covered as well.
Okay. And of course, remember the much touted grandmother theory. Now, actually, this was a patient whom we had who had multiple platelet transfusion. She had a hereditary defect of platelets and she had multiple platelet transfusions. And that's why probably some of this might not have been negative platelets. So that is why probably she became positive. And now this is the common scenario we have. We have a second gravida who will receive full anti-D prophylaxis. Would you still recommend testing for the Rh antibodies when she comes for her second pregnancy? Rohan, would you like to take this first?
Yeah, ma'am. I would, irrespective, I would still want to do the ICT for her to just ensure that there is no alloimmunization. Ma'am, because sometimes what happens is, even though she may be a negative mother with a positive baby, the anti-D may have been given late in the first pregnancy. Generally, it's recommended within 12 to 24 hours, you should be giving the anti-D prophylaxis, but sometimes it may get delayed, but that doesn't mean you don't give it. So sometimes it's even given 48 to 72 hours later post the delivery as well. So sometimes that can lead to a failure of the prophylaxis, and that's why you should, irrespective, be a little vigilant even in the second pregnancy as well, to ensure that there's no alloimmunization and the baby is not at risk. And if it is, then you can take the necessary precautions as the pregnancy goes on further.
So, Dr. Nirmala, would you like to add something to this?
See, basically the anti-D that we give, which we normally give about 300 micrograms after the delivery, it should suffice for majority of the fetal-maternal hemorrhages. Because, the fetal-maternal hemorrhage that happens, it's not a large fetal-maternal hemorrhage. And they say what we normally give as 300 should be adequate for, say, a vast majority of the pregnant women. But in very rare situations, say you have an abruptio placentae, or you may have some intrauterine manipulations, or twin delivery. That is why when we teach the postgraduates, we tell them that during a C-section, don't be in a hurry to remove the placenta manually. We always wait for the uterine contractions to come, let the placenta separate on its own, and then you remove it. So sometimes the amount of fetal-maternal hemorrhage may be more, and our standard 300 micrograms might not have been adequate. So I am sure Dr. Prasanna will agree, there are some centers where they routinely do a Clay-Hoyer test just to find out how much of the fetal-maternal hemorrhage is and whether whatever we have given is adequate, or the transfusion medicine specialist would say, no, the fetal-maternal hemorrhage has been a bit more, so you may have to give probably a bit more anti-D. So these could be the reason why, there is an apparent failure of the prophylaxis.
Okay, so we've seen two major causes. One is she might have gotten sensitized earlier in the pregnancy. And secondly, she would have had a much larger fetal-maternal hemorrhage, which has not been covered by the standard dose of anti-D. And Dr. Prasanna, if she were Rh positive, would you still recommend an antibody screen?
Yeah, Sita, before that, can I just put in an add-on to the last question?
Yes.
It could also be that it's not an anti-D antibody. It could be an antibody to something else, and therefore your anti-D has not covered the prophylaxis. I mean, has not been prophylactic. Now, for this, to answer this question, even if she is Rh positive, yes, you will do an antibody screen because you can have hemolytic diseases of the newborn due to many other antibodies. And I'd like you to, at this stage, just to take the audience to the form that we have. If you look at this form, we have a whole lot of investigations which are done, and specifically for the obstetrics group, it's mentioned over there, blood grouping plus IAT, which is an IgG IAT. And all our obstetricians always mark out blood grouping plus IAT as the first investigation when they're looking at a primary gravida.
So we've actually started doing this for almost the past 1 year.
Sita, can I come in? These autoantibodies, we normally don't routinely do it. If a patient is Rh negative, I mean, the other autoantibodies causing this kind of a problem is, I'm not very sure what is the percentage. So majority of us will only do an antibody if the lady is negative and the husband is positive. Routinely, we don't ask for an autoantibody. When I was in UK, when I was a registrar, we used to do this autoantibody screen, but somehow this does not form a routine practice in our clinical practice because the number is very small.
So the RCOG guideline actually says that all women should have their blood group and antibody status determined at booking. Probably when we are going to give our antenatal prophylaxis is going to be effective, probably we'll be seeing more of non-D antibodies. Now, Dr. Prasanna, when the blood group is checked in antenatal women, can there be any discrepancies? Is it just black and white, Rh negative, Rh positive?
Sita, can we just go to that picture which I put up just to describe it? Yeah, to make it very simplistic, I put a picture which says RBC with normal amounts of D antigen Rh positive, no D antigen Rh negative. Now, the gray zone which many of us in transfusion medicine face is what we call the weak Ds and the partial Ds. Now, when you say weak D, you find that the antigenic sites are much, much less when compared to a normal D. And when you say partial D, it means certain epitopes are missing, and therefore people can, generate antibodies against those epitopes. We'll go over to the next slide. Now, in practice, what does this all mean? I've just put up what we call a column agglutination technology to illustrate to all of you how we are doing blood grouping in the blood bank. And if you see the arrow on the top, you see that that's a very clear 4+ Rh positivity. Now, where we have problems is at the arrow in the bottom, where you find that it's not a clear plus, it's something like a 2 or a 3+, and then we do not know whether this is a weak D or whether this is a partial D. And therefore, when this is a patient who has this problem, we consider them Rh negative, and we say give negative transfusions and give them Rh anti-D after their delivery or during at 28 weeks. And when it's a donor population, we say consider them Rh positive. So there's a huge gray zone over here, and I'm not going to take this into consideration now, but genotyping is the answer.
So the general rule of thumb is when they are blood donors, treat them as positive. When they are recipients or during pregnancy, treat them as negative.
Exactly.
Now, Rh antibodies detected in pregnant women, whether they're positive or negative, have two major issues. The risk of hemolysis and fetal anemia with resultant increase in perinatal morbidity and mortality. And the second problem is, which we sometimes ignore, it may hinder the timely provision of blood and blood components due to difficulty in obtaining antigen-negative blood or cross-matching issues. And this may become a problem if the patient is at high risk of hemorrhage, like placenta previa or placenta accreta. So it has to be kept in mind. Now, once we have detected this antibody, how often should antibody levels be monitored, and what threshold should trigger further testing? Dr. Nirmala?
In the primary gravida, once you detect an antibody, you would like to know the titer because you would like to know when to intervene. So once antibodies are detected, I would like to monitor them. Probably you said she was at 12 weeks. So before 18 weeks, nothing can be done. So probably I will repeat it after 4 weeks when she's like 16 weeks. And then depending upon the RH antibody titer, from 18 week onwards, I would talk to my sonologist, because that is when he can also help me as to what I should be doing. So if I detect antibody very early on, I would monitor her very closely.
Okay, so every 4 weeks we do the antibody titer in dilutions. So what dilution would make you feel alarmed? If it's positive, in what dilution, what threshold?
See, normally we get it as 1:4, then 1:8, 1:16, then 1:34, like that, you know. But then when I get an antibody being positive, and when I think I will be able to salvage the fetus, say from 18 to 20 week onwards, then I would also get my sonologist involved to look at whether, you know, what is the critical threshold. Because in practice, Sita, we have found that and these antibody titers also, they actually vary from various labs. So some lab may say 1:32, 1:64. But then when you send the patient for a scan, they may say the baby already is anemic. So whenever I'm not going to wait for a critical threshold of say 1:258 or whatever, but whenever the titer is in an increasing titer, first I do it's 1:4, then I do it's 1:16, then it actually rings an alarm for me. Then I would like to get the sonologist involved, because looking at the middle cerebral artery, and they would be able to tell me, you know, when the baby will need an intervention. Because what we are looking at is, when is the critical time the baby is going to get anemic, and when is the time that I need to intervene. That's all I'm interested in.
Okay. So an antibody titer may not be very useful in a patient who has had a previous baby which has been affected by RH immunization. So we assume that the fetus is at risk irrespective of the antibody titer.
No, here we are talking about this primigravida. No, this is our lady is a primigravida.
Okay. No. So if you have a second gravida and her previous baby has been affected, then you're not going to use antibody titers.
No, of course not.
Okay. We'll just see a little bit more about antenatal management. Is dating important?
Very.
Okay. So dating is actually critical in such patients, because you need to decide about many things a little later in pregnancy. Potentially sensitizing antenatal events. Can you give us an example and how we are going to manage them? Is Dr. Rohan there?
I think he left. He had a call. He sent a message. He got a call from emergency LSCS.
Oh, okay. Sorry about that.
Sita, should till Rohan comes, should I just carry on with that, or
please,
we'll wait for
Dr.
Rohan?
Nirmala.
No, because whether we need to wait for Rohan or what should we do?
No. So let's continue the discussion. Give us an example of a sensitizing event antenatal.
Okay, just generally for all the postgraduates, any bleeding in pregnancy will be a potentially sensitizing antenatal event. Say it be a threatened abortion or repeated episodes of bleeding, a placenta previa with a bleeding, any invasive procedure, so you just think of any small bleeds in pregnancy, be it a threatened miscarriage, and ectopic, don't forget, molar pregnancy, but that's only for, sensitization. So just in a nutshell, any bleeding in pregnancy is a potentially sensitizing antenatal event. Any intervention in the form of amniocentesis or your CVS or an external cephalic version will be a sensitizing event. So these are all in the antenatal period you need to think.
Sir, if you need to do an invasive testing in an antenatal negative woman, or in the presence of antibodies, would we still go ahead?
Yeah, supposing you're doing your 12th week scan and you need to do a CVS or an amnio, you definitely have to go ahead and do it. And then in a non-sensitized lady, you give her an antenatal prophylaxis after your event.
How about non-invasive testing for fetal RSD status? Sir, would you like to take this question?
Yeah. So non-invasive testing for RT status is possible. It has got
Suresh, can
yes.
you be a little louder? Can't hear.
Okay. Is it better now?
Sir, your video is
it better now?
Little louder, Suresh.
It's better now.
Okay. So RHD status by non-invasive testing by cell-free DNA is possible. It has got 99.9% sensitivity. And the question is, if you want to routinely do it for all patients, where does it help? Actually, it helps in the fact that it can reduce the, 1 second. I'll just give me 1 second. Okay, so antenatally you recommend anti-D prophylaxis. But if you do a cell-free DNA and prove that the baby is Rh negative, then you can avoid the prophylaxis completely. So ROGAM can be avoided in these patients who is already having an RHD negative fetus. So unnecessary ROGAM injections and unnecessary indirect Coombs test, repeating that Coombs test every time she comes, all that can be avoided by doing it has got a 97.3%. In 97.3% of women, we could actually avoid unnecessary recommendation of anti-D prophylaxis.
So although the RCOG recommends, yes, sir. So it recommends using maternal blood. It's possible to test for these antigens.
Yeah.
But it's not.
So it's very cost effective. It is not
cost effective for us. Yes.
Very expensive.
Very expensive. So now at 20 weeks, we find that the titer is gone to 1:32. How would we monitor for fetal anemia, sir? The patient.
Okay. So so the thing is, will I be able to share my screen?
Yes, sir.
I have a few things to show. So if you stop sharing, then I'll share. So first and foremost,
yes, we can see you.
Yeah.
We can see your slide, sir.
Are you able to see my screen now?
Yes, the slide headed fetal anemia. Yes.
So the whole question is, when the baby is anemic, we need to identify the baby that is anemic, and the baby not only anemic but needs an intervention. So for us to say that the baby is anemic, the hemoglobin should be more than 2 standard deviation below the mean, or the hematocrit should be less than 30%. Okay. The fetal hematocrit should be less than 30%.
Okay.
And this table gives you the hemoglobin concentration various stages. So one of the things that was discussed a few minutes ago was about the antibody titers. Yes, I have a small differing point of view. Serial antibody titers are not required, because once the woman is ICT positive and the titer is more than 1 in 8, then she is already sensitized. Now, all that we need to know now, our focus shifts from the mother to the fetus. When you do serial antibody titers, it is not going to tell me, I identify the baby which is going to become severely anemic. It is not going to tell me that. So I would rather go and test the fetus directly, And when I do the fetus directly, I go for MCA Doppler.
Okay.
And when I do MCA Doppler, when it is less than 1.5 MOM, you just follow up in 2 weeks for repeat MCA and further follow up based on MCA PSV. If it is greater than 1.5 MOM, then I go and take action. So that is that's all. So MCA PSV is probably the best one till date. It's got about 98% sensitivity. The most important thing is to do it correctly. Okay.
Yes,
and, so when you do it, when you place your sample volume very close to the origin and ensure that the angle is 0 to 20 degrees. And the angle is less than, and that I think is the most important. So this is how we do the identify the baby with anemia.
Okay.
I'll stop sharing the screen.
Okay.
Yeah.
So MCA has MCA PSV has been accepted as the test of choice. We don't do any other test now.
Nothing. We don't do anything else. That is the test.
Okay. So when would you?
Suresh, can I clarify one doubt? Supposing at 20 weeks you are doing an antibody titer and it is 1:8. You are saying that we need not have to do any other antibody titer. Is that the way that I understood, right?
Yes.
Yeah.
Yes. No need.
So,
because we follow only with MCA Doppler.
So from then on, you follow her with the MCA Doppler every 2 weeks, is it? Is there a critical value after which I'll see, supposing the patient is not in Chennai, I need to send her to Chennai and I need a cutoff, so that I know that I'm not making the patient come often. In that case, is there a cutoff?
No, unfortunately, there is no cutoff. 1 in 16, some people say 1 in 32, but actually all those things don't work. We have had 1 in 16 baby hydropic. We have had 1 in 256 baby non-hydropic. Because RH is beyond titers, it is how much of hemolysis that happens to that particular baby that is going to matter.
Can I just
so MCA Doppler is the only way. Yes.
Yes, Prasanna.
Can I just put in one point, ma'am? You were asking about this. The only antibody where I know that it's immaterial for you whether it's 1 in 16 or 1 in 32, but the only antibody where you go right down to the bottom, even if you get a titer of 4, is an anti-Kel. So when you have even a 4 titer with an anti-big K, you have to be very, very worried about the fetus because it has a habit of accumulating faster.
Thank you. Thanks.
So this is a test of choice for monitoring for fetal anemia. So when would you decide, sir, whether this baby needs an intrauterine intervention? One is the gestation age, we all know. So when would you decide and how do we go about doing it? Today, sir, this.
Hello?
Screen point.
Sir.
Yeah. Yes. Can you repeat the question because I lost the question?
So this is about intrauterine transfusion.
Yes. Yes. So you want me to tell you about the?
So now you monitor it is less than 30. About intrauterine transfusion.
Yes. Okay. So I'll share the screen again.
Yes, sir.
Just 1 second. I'll just share the screen again. Yeah. So let me just move a few slides here. So sorry. Okay. So when we talk about transfusion, there are a few things that we mean when we want to manage the case of suspect anemia.
Yes,
when we need, first of all, blood to be given to the baby, and that has to be O negative blood. Second is this O negative blood should be packed cells with a hematocrit of greater than 80%. This is to minimize the total volume that we can transfuse to the baby. Second is it should be fresh, irradiated, CMV negative, and of course leukodepleted. So this is mainly to prevent graft versus host disease. The next is how much volume we want to give. Now, as we know, the fetal blood volume changes with gestation. So here you have a chart which tells you for every week what is the feto-placental blood volume. The most important thing, remember, a baby after birth versus a baby before birth is the volume. The fetal vascular compartment is not only the fetal vessels but also the placental vessels. So together, say at 30 weeks, the fetal placental volume is 125 ml. Then we take the fetal hematocrit. Then we also do the donor hematocrit is known from the blood bag. We put a needle and aspirate a little bit of blood and the fetal hematocrit. And then there is a multiplication factor. There are several formulae which we can use for calculating the volume of transfusion to be given. This is one such method where you identify multiplication factor, you multiply the fetal-placental volume with this factor, and you get the transfusion. Then you go to the transfusion set. The first step is fetal immobilization, because we give an intramuscular injection of atracurium or pancuronium into the deltoid muscle of the baby, and within a few seconds, the baby is paralyzed. This helps the baby not to move. Then we have several routes in which you can give intrauterine transfusion. And this, for example, is we are going through the umbilical cord, base of the umbilical cord and placental entry site. But the best site which we find is through the intrahepatic portal vein. So you can see the needle going into the portal vein, and then we can transfuse it. The advantage of this technique is, supposing the baby moves or the needle is dislodged, then the blood which you give will become an intraperitoneal transfusion, which is still fine. Whereas when you are giving it in the umbilical cord, sometimes cord hematoma can form and the baby can go into bradycardia. So that is the advantage which you do. Then, of course, we have to ensure that the transfusion is giving at the rate of 2 to 3 ml per minute. And we have to give it very slowly, watching the fetal heart, and then we monitor the cardiac and the cardiac status as we go along. And then lastly, of course, once we keep on checking the hematocrit of the baby. Once we reach a hematocrit of about 45 or so, then we stop the transfusion. And then immediately post-transfusion, you can see the MCA peak systolic velocity will reduce. And then we follow the baby 1 day later, and then follow up every 2 weeks after that.
Okay. So that was very clear. We could go through the procedure. How early can we give an intrauterine transfusion?
So the earliest we have given is about 17.5 weeks. But it is preferable, the risks are much higher at that stage. It is technically also very difficult. So sometimes we do a small intraperitoneal transfusion at 17.5 weeks, get her back at 18.5 weeks. But usually after 18 to 19 weeks should be okay.
Okay. So how would you time the subsequent transfusion? You actually explained it, but how would you time a subsequent transfusion?
So here is the slide which tells you that the timing of the initial assessment is done after 2 weeks. See, it all depends on how much you have increased the hematocrit of the baby. Supposing you have been able to give a full transfusion, usually the rate of fall of hematocrit is about 0.8 to 1% per day. So if you have brought it to 45 and if it falls at 1% per day, usually it will take another 15 days for it to come down to 30. So 30 is our limit. So we usually call it 2 weeks later. And then when you do a second transfusion, interestingly, what you find, is the bone marrow is quite suppressed at this time. So the number of fetal cells produced will be less, and the rate of fall of hematocrit is not 1 per day. It comes down to 0.6 or 0.8 per day. So then what happens is you can give a longer interval between transfusion. We monitor by the MCA, but the MCA cutoff for the second transfusion is not 1.5 mom, but it is usually 1.7 mom. So you wait till 1.7 mom before you give that. Some people don't believe that the MCA is useful for repeat transfusion, and they periodically call the patient and keep giving transfusion. But we believe in MCA mom subsequently also, and then also we calculate the rate of fall and then take it from there.
Okay. Okay. Can we
Minimize.
sir, can we minimize the screen? Can we go back to the question screen?
Yeah, you can do it now.
Yeah. Okay.
I'll stop sharing. You just have to say share screen.
Okay. So these are all the questions which we already discussed. We have to keep the donor blood ready. You do it in the same sitting, no, sir? You test the hematocrit and
Yes, I prefer do the same sitting because after the advent of MCA Doppler, there is no need to first do a blood sample and then do, because the cross matching is done with the mother's blood, not with the fetal blood.
Okay.
Yeah.
So how difficult is it to irradiate this blood? Dr. Prasanna?
Sita, you have dedicated blood cell irradiators, which some blood banks, especially in oncology centers, do have. And you expose the blood to 1,500 gray units and you deplete the lymphocytes from the blood. Now, just in case you don't have a dedicated irradiator, you can jolly well go ahead and use one which the oncologists use, your linear accelerator, stick it in, and it may not be that correct, the amount of dosage, but then it works. And we have used it under circumstances. The only other thing I wanted to add on to Dr. Suresh's qualifications for the donor blood is that, especially in Coimbatore, I'd be very careful about also checking the donor blood for a sickle, to see that they're sickle negative.
Okay.
And the blood should be less than 7 days old.
Okay. Next. So now we'll go on to antenatal Antibody prophylaxis. So who should get it? What should we give? When it should be given? What is the dose? Does it have any risks? What are the advantages? Dr. Nirmala? I'm sorry, yeah, because
I know Rohan has left, Okay.
I know, I'm really sorry.
No, that's okay, Sita. Chitra in her slide, she said that routine postpartum prophylaxis has brought the RH isoimmunization level to 2. So if you want to reduce it further, and if you want to take care of the antenatal events, many of us follow the routine antenatal anti-D prophylaxis. This is routine, not when there is a sensitizing event. So I would like to give one dose at 28. There are various recommendations, RCOG says you give it at 28, and again after 6 weeks, you give it at 34. Then you check and give it at 40. That is a little cumbersome, So what I do is I give one dose at 28. We used to have Rogam, which I think is polyclonal. Prasanna may correct me if I'm wrong. I'm a pure clinician. I wouldn't know too much about this monoclonal, but I think now we are getting the monoclonal antibody. My understanding of this polyclonal and monoclonal is very similar to the platelets, the ferrased platelets and the routine platelets. I think monoclonal is better. Prasanna can add a little. And the timing is 28 weeks. I would like to give a single dose at 28 of 300 micrograms. Advantages is there are some antenatal sensitizing events which are occurring. So if you could give it at 28 weeks, you can further reduce the isoimmunization level to a very minimal. Maybe from, you can bring it down to say from 2 to 1. That is the advantage. The risk is like 1/3 of the Rh negative women may carry an Rh positive baby, so they might not need it. That is one. Second is very rarely some people can develop a reaction, which I've not seen it in clinical practice. So in my mind, the advantage is you are bringing down the immunization to a very negligible level, and you are taking care of the antenatal events which are causing sensitization. The only risk is maybe it is not cost effective in 1/3 of the women, because in 1/3 of the women, the baby may just be Rh negative and you're just giving it, and very rarely the people may develop some reaction.
Just to summarize that, you should give it to all antenatal Rh negative women who are not immunized. So once you're immunized, then of course it loses its purpose. So we are all polyclonal, but there is a monoclonal which is available, which goes because polyclonal comes from the serum of people who are already immunized. Single dose at 28 weeks is, I think that's what all of us follow. The risk means that Rh negative women, 40% of them may carry an Rh negative fetus, in which case it becomes not necessary. Okay, so this is again, we've already discussed this. You all give anti-D when you have a potentially sensitizing event, all first trimester spontaneous induced or threatened abortions. It's not necessary for spotting, but if she has bleeding, you give it. A higher dose is given in ectopic pregnancies because the blood enters into the peritoneal cavity. All invasive prenatal diagnostic or therapeutic procedures, blunt abdominal trauma and external cephalic version. Bleeding in pregnancy, the dose depending upon the trimester and the probable amount of fetal-maternal hemorrhage. Now, suppose the patient goes on having hemorrhage, you're supposed to, you may have to give a repeat dose. The recommendation is you do an ICT and find out if there are excess antibodies. If there are excess antibodies, you don't have to repeat the dose because the half-life is 24 days. Very rarely mismatched transfusions you can have. And of course, Rh negative women who have received a platelet transfusion will probably have to be covered. Now, are there any adjuvant antenatal treatments, for example, targeting the maternal immune response?
I'm not aware, Sita.
Okay, so actually when I was reading, I just found two things, that is the plasmapheresis and IVIG. These actually bring about an immunomodulation in the mother, and this is supposed to be very effective. You have discovered antibodies very early, for example, at 12 weeks. Until 18 to 20 weeks, you want to carry on the pregnancy before it becomes, safe to do an intrauterine transfusion. So I found this very interesting case report in the hematology manual. This actually shows a patient who had antibodies discovered at the very beginning, that is at 12 weeks. She was monitored, the little arrows there. Actually, in the first half of the graph, the arrows show the administration of, this is the all these arrows are the administration of IVIG. Okay, and this is the MCA-PSV. So the MCA-PSV remains below 1.5 MOM, and then after 24 weeks, when it starts rising, all these little arrows show intrauterine transfusion. So this patient was carried on to 35 weeks, after which he was delivered. Dr. Soumya, I'm very sorry you had to sit. Can you tell us a little bit about IVIG in the neonate? Dr. Soumya?
Can you hear me now?
Yes, I can hear you.
Yeah. So, intravenous immunoglobulin has a place in the treatment of babies where you're waiting for blood to be organized for an exchange transfusion, or in some babies where the serum bilirubin is climbing, but it has not yet reached exchange transfusion level. So it can be used in babies where you're waiting for blood to be reached for an exchange transfusion, where there is a clear-cut indication for an exchange transfusion, or when serum bilirubin levels are climbing and you want to use intravenous immunoglobulin as an adjunctive to intensive phototherapy. And the way immunoglobulin acts in a baby is it displaces the anti-RHD antibodies that are going to attack the baby's red blood cells, and thereby it prevents hemolysis. So this is the way it works in the newborn baby.
Okay. Okay, so we'll just summarize the antenatal care. We've already seen that all antenatal women should have their blood group and antibody status checked at booking, although there was a lot of controversy about that. Accurate pregnancy dating is critical. All of us would agree with that. Monitoring with antibody titer. We saw the screening intervals, the pitfalls, and where it is not sensitive. Antenatal prophylaxis, management of potentially sensitive intrauterine transfusions. Now we go on to the next thing, planning delivery. The patient is now 32 weeks with an estimated fetal weight of 2 kilos. With normal Leica and Doppler parameters, the last intrauterine transfusion was 3 days ago. So what is the optimum timing of delivery, mode of delivery, and place of birth? So she's all yours, Doctor. Okay. When would you like to deliver this patient?
See, this is a lady wherein we have successfully brought her up to 32. So this is the time that you discuss with your neonatologist. Ideally speaking, our neonatal outcome is very good after 34 weeks. So I will also check with my sonologist and ask him whether it is okay to wait for another two weeks more. So when you're wanting to deliver, do not forget to steroid the lady. And if you're a person who also, talks about neuroprotection, you think about your mad self. The optimum timing of delivery would be 34 weeks when our neonatal outcome is very good, but this can change from unit to unit. So you also involve your neonatologist in the decision making and also talk to your sonologist. This is the time when you really have to pick up your phone, talk to them, because this is a precious pregnancy and we have brought her up to a period of viability, and we want a reasonable neonatal survival without any neonatal morbidity. We are not talking about mortality. Mode of delivery, I would actually go for an elective cesarean section because this is already a compromised baby and I wouldn't like to really allow her for, an induction and a delivery. A place of birth should be a place where the neonatal intensive care is available. Supposing you are in a unit where you've been taking care of her, it is better in utero transfer to a unit where all the facilities are available rather than deliver the baby and then move her out. So this is how I would look at it. So I would definitely involve my neonatologist, and the patient will actually talk to the neonatologist because there are two things, Sita. One is prematurity. Second is the cost. The cost of smaller babies come with big bills, and we are looking at a baby which will be needing, probably an exchange transfusion, probably a very long stay in the intensive care. So your decision to deliver will depend upon one, what the sonologist tells you, and second, once you're comfortable delivering, which will be around 34 weeks.
Suresh sir, what would you recommend? How long would you, sir?
We have a very, as far as RH isomanized baby is concerned, we would like to ensure the pregnancy reaches term.
Okay, sir.
There is no need to deliver it early. If you have treated it adequately, the last transfusion we can give up to 35 weeks.
Okay, sir.
So we don't hurriedly deliver at 34 weeks. Give the transfusion 35 weeks, take her up to 37 or 38 weeks and then deliver. These baby neonatal course will be much better because I don't think any neonatologist is happy about a premature baby with a problem like this.
I have a
I would be very happy with you, sir. So
Sita, I have a slightly different view with Suresh because the more number of invasive things I do, the more I will be worried. So by 34 weeks, when I look at my own neonatal, outcome in my unit, I'm quite happy about it. So instead of putting, that is my view. I would probably take her up to 34 and I would be quite happy, steroid her, Maxelf her, deliver her.
Can we, Soumya, what would you?
I think we have to be, sorry, in this.
Yes, sir.
Yes.
Sir, you can continue, sir. We're waiting.
Transfusion at a baby at 34 weeks was 37 weeks. Yeah. Yes, neonatologist, please.
Yeah.
Neonatologist, please, because giving a exchange transfusion at 34 weeks versus 37-week baby, which do you prefer?
I would definitely prefer doing an exchange transfusion on 37 weeks compared to 34 weeks because of the inherent risks of the procedure in smaller babies. Having said that, when babies receive intrauterine transfusions, sometimes you might just get away by giving a simple packed red blood cell transfusion. But that is a very, very optimistic scenario. And sometimes babies may go on to need one or more exchange transfusions. So we should also bear in mind that at one end of the spectrum, you can have babies who will get away with a simple PRBC transfusion. On the other hand, you will have ongoing hemolysis and you may need to do exchange transfusions more than one time.
So the babies tolerate transfusions better than exchange transfusions because the fetal-placental unit takes care of the volume overload.
Yeah. No, intrauterine transfusion is far better because it can be done very safely. It's a safe procedure, and getting the baby to near term is always better. That's the standard followed in fetal medicine service.
Okay. But we followed Dr. Nirmala and she was taken up to elective section and she delivered a female baby weighing 2.3. So is cord clamping immediate or delayed, Dr. Soumya?
Well, there are a lot of benefits to delayed cord clamping, both in preterm babies and term babies generally. So the general benefits of delayed cord clamping would be reduced incidence of intraventricular hemorrhage, necrotizing enterocolitis, and all other morbidities associated with premature babies. In term babies, there is a reduced incidence of iron deficiency anemia. So these are the general benefits. But in a situation like RH isoimmunization, again, delayed cord clamping is advocated because it produces a higher hematocrit value for the baby. Therefore, the baby is able to withstand and need less of transfusions later on. So definitely delayed cord clamping is advocated in RH isoimmunization as it is in all other situations. And the other important message I wanted to get across is when you are cutting the cord, please leave about 5 or 6 centimeters so that the neonatologist can use the cord, catheterize the umbilical vein if an exchange transfusion is needed.
Okay. So what tests would you like to perform with the cord blood?
The cord blood on the baby, we would like to do routine blood grouping, RH typing, Coombs test, do a hemoglobin, a serum bilirubin, and we would like to proceed from there. On the mother, of course, we would be doing the indirect antibody test.
One small thing.
Yes, sir. Yes, sir.
When you do the blood test in the neonate, please remember if you have given an intrauterine transfusion, the baby will be O negative. Yes. It will type as O negative only.
Yes.
Whereas the first time when we do the intrauterine transfusion, at that time the baby's blood group must be ascertained, written in the case sheet clearly, so that the neonatologist can understand following up.
Okay. So
baby's
that's
own blood group will come after 4 months.
Okay. Dr. Soumya, is there a difference in the clinical presentation of a neonate who has received intrauterine transfusions?
Yeah, as I mentioned earlier, we may get away by doing just a simple packed red blood cell transfusion. Some of them may need exchange transfusions. But the most important thing to know is that even if the baby looks to have an apparently normal course in the immediate newborn period, we should keep following up these babies because some of them have an incidence of late anemia. This late onset neonatal anemia may present at 4 weeks or 6 weeks, and this is because of the effect of intrauterine transfusions. As Dr. Suresh had mentioned, they have an effect of suppressing erythropoiesis in the baby. Plus, the transfused red blood cells die out. So at that point, that is between 4 to 6 weeks, we'll have a drop in hemoglobin values, and the neonatologist should be prepared to anticipate this drop and should be able to treat the baby with the PRBC transfusion.
Okay. So, what is the threshold for an exchange?
Once we have a baby like this baby was delivered at 34 weeks, we do a cord bilirubin level, and then we serially monitor the bilirubin level while putting the baby on intensive phototherapy. Once the bilirubin level starts climbing at a rate more than 0.5 milligrams per deciliter per hour, then we have various charts. These take into account the weight of the child, the postnatal gestation of the child, the presence of additional risk factors like perinatal asphyxia, sepsis, low albumin, etc. And based on these normograms, we can decide whether the baby is needing an exchange transfusion or not, and then plan the exchange. And in babies who are waiting, who are on intensive phototherapy, whose levels are climbing, we can also try intravenous immunoglobulin because this will also have an effect in deflecting the antibodies from the baby's red blood cells and bring down the hemolysis.
Okay, so now we move on to postnatal anti-D prophylaxis. When should it be given? Dr. Nirmala?
As soon as you know the baby's blood group, ideally 24 hours, but definitely you try to give within 72 hours. But for whatever reason it has been missed, there is some benefit if you give up to 10 days, but not after that. So just to confirm, ideally within 24 hours, as soon as you know the blood group of the baby, but at least 72 hours.
Okay. So can it be omitted under any circumstances? What if the patient says
when I was a postgraduate student, when a patient is undergoing a concurrent sterilization, they used to omit giving anti-D, but nowadays, I think we do not know her future obstetric carrier. So I think you follow the rule and try not to omit and just give it to everyone across the board. Because this is now it is very available in all the medical colleges also. But I remember, Sita, when I was a postgraduate in the exam, this is the question they'll ask. And then if you say they don't say that your prof will say, oh, you want to waste all the money. So I remember that, but then you just give it for all the patients.
Okay, the question remains the same, but the answer has changed.
Absolutely.
Okay. Now, at delivery, it was found there were 50 grams of RP clots. That means she has a little bit of abruption. What is the significance?
More feto-maternal hemorrhage. So this is the time when I will talk to Prasanna and ask her whether I need to quantify the feto-maternal hemorrhage by doing additional tests, whether my routine 300 micrograms is going to be sufficient, or whether I need to give an extra dose of anti-D. When you work in England, when you're sending the blood, they will calculate and they'll tell you how much anti-D you need to give. Whereas in our country, we are not doing it because the 300 micrograms that we give, it takes care of, I think I do not know the exact number, but it takes care of the feto-maternal hemorrhage in majority of the situation. But if you are having a situation where because of an abruption, the abruption is so severe that you have a stillbirth, then you do not want this lady to have a problem of RH also in the next pregnancy. So that is the time when you should talk to your hematologist and ask her whether we need to give any additional dose of anti-D.
Okay. So Dr. Prasanna, what tests are available?
Just to answer that question, Dr. Nirmala, usually the 300 micrograms of anti-D looks after about 15 ml of fetal RBCs, or they say 30 ml of fetal blood, which is in the mom's circulation. The test you could do is the Rosette test, which is actually just a screening test and tells you if there's more than 10 ml of fetal hemorrhage into the maternal circulation. You don't stop there. You have to do a Clay-Haw-Betke test, or what you call the acid elution test. And I think Dr. Nirmala has been talking about it. You have these cells which contain HbF, which are explicitly resistant to acid elution, and therefore they stand out as magenta colored cells, and then you quantify them. It's a very, very labor intensive, unstandardized test. You're supposed to count 2,000 of these cells, and then there's a formula by means of which we can tell you how much of anti-D you have to give the mother. Then there's flow cytometry, and I think many centers in the West have gone on to flow cytometry, but not cost effective at our stage.
Okay, the last part is other red cell antibodies. Are they clinically significant and capable of causing hemolytic disease? We'll start with Prasanna, then we'll move on.
Yes, it's not just anti-D. In the same breath as I say anti-D, I'd like to say anti-little c and anti-big K. They all come in the same spectrum. And then you have other antibodies like anti-big C, anti-big E, Duffy, the KID antibodies. All of them are known to produce hemolytic disease of the newborn. Very rarely, you can also get Duffy. The Duffy group can also produce hemolytic disease of the newborn. And I think as we are going through our careers, 30 years ago, I would have only spoken about anti-D. But now as I'm going through my career, I find that we're seeing less of anti-D and more of the other antibodies. Sometimes it's even an anti-M.
Dr. Suresh, have you seen any other antibodies other than anti-D?
We've had one case of KEL many years ago, and one case of little c. That's also very rare, but what happened was when this woman needed a transfusion, we were trying to cross-match the blood, and we found many donors not cross-matching at all. And then that prompted us to investigate further and found that it was actually a KEL.
So anti-KEL is supposed to be different because it produces erythroid suppression in the bone marrow. So the baby does not respond to anemia. So maybe when anti-D prophylaxis is becoming more and more universal, we would probably see more of these antibodies. Dr. Nirmala, would you like to comment on this?
I would say I haven't seen even RH, we are seeing less of RH isoimmunization. But I would like to definitely take Prasanna's point. As the RH immunization cases get lesser and lesser, the other antibodies will get more and more. So I think you should be aware of it. I'm not even sure about the percentage of the KEL and other antibodies in our own population. What is very important is it prevalent in our own population? Is it clinically significant for me as an obstetrician? And that I need to know.
I'll answer that question. Can I, Sita?
Yes, please.
Yeah, to answer this, how prevalent is it, ma'am? Universally, the incidence of these antibodies hovers around 1%, that's all. But my point is that whether it's 1% or whether it's 50%, when these antibodies arise in a patient, they are of a headache to anybody, because you cannot have the patient, an unbooked patient, lying on your operation table and you asking for blood. And like Dr. Suresh said, we're not able to get blood. So it'll be really very nice, whether a patient is RH negative or positive, that they're screened right in the beginning for all these antibodies, so that the blood bank is prepared to get blood which is phenotypically matched as far as possible. To add on one more point, we are actually planning to do a phenotyping of all our donors, at least a limited phenotyping, RH KEL, looking predominantly at women who could possibly be immunized antenatally.
So if I may ask you, Prasanna, like RH antibody, the percentage varies between Caucasians, Asians, and white people. But you're saying for anti-KEL, it doesn't vary. The percentage is just one across the globe. Is that what you're saying?
What I meant is that Caucasians, I meant Indians, Caucasians, the whole lot of us. Maybe there's a small difference between us and the East Asians, where KEL is concerned. Generally, it's about 50% in our population. 50% of us approximately have the KEL antigen and 50 do not. And there are studies from India also, ma'am, which tell us.
Thank you. Thank you.
Madam, can I add something to this?
Yes, please.
As a neonatologist, now with the use of RH anti-prophylaxis, we are seeing more and more of ABO incompatibility present with neonatal jaundice. So fortunately, ABO incompatibility does not affect the fetus in vitro. So we have time to prepare for it, and we can detect these babies. Once they are born, we do a routine RH typing and also a Coombs test on. You will be able to pick up babies where there is an ABO incompatibility. Maybe the mother is O positive and the baby is either B or A. And many of them may develop jaundice within the first 24 hours of life. So overall, we are seeing that ABO incompatibility has become the most common reason for us nowadays to do an exchange transfusion.
Point well taken.
Okay. Okay. So we are coming to the end. I think. Okay. So there's still place for a lot of research in RH isoimmunization. Probably we should think of RH genotyping. Prasanna would be very happy if we're able to do this. Polyclonal antibody is safe, but still there are concerns about viral and prion disease. There's some neurological disease which could be transferred, so monoclonal antibodies may become more popular. Fetal RH genotyping so that you can limit administration of antenatal antibody to women carrying an RH positive fetus. Avoidance of exchange transfusion in the neonate, use of IVIGG or heme oxygenase inhibitors. Thank you, panelists. There are a lot of questions. So I think, can we spend the next 10 minutes answering these questions?
Yes.
Mr. Subbu, can we have 10 minutes more? Because there are a lot of questions which we have got.
Subbu, can we have 10 minutes?
This question is to Dr. Nirmala. For twin pregnancy.
Ma'am, go ahead, please.
Okay. Yeah.
Okay. This is to Dr. Nirmala. For twin pregnancy at 28 weeks, is 300 micrograms enough for antenatal prophylaxis?
Yes.
Okay.
We don't increase the dose for twin pregnancy. We don't double anti-D. We give a single anti-D 300 micrograms. Prasanna, is that correct?
I suppose so. I really won't be able to comment.
Yeah, we don't increase the dose because it's twins and triplets.
Yes, I think so too. If you do a cervical encirclement, will you give anti-D for an RH negative woman?
No, it is when there is a feto-maternal hemorrhage. Here you are only pricking the cervix. It is different from your CVS or an amnio. So there is really no need to give an anti-D when you do a circlatch.
This is to Dr. Prasanna. How long will ICT be positive if we give anti-D prophylaxis?
Roughly about 3 weeks, 21 to 24 days. That's what we said.
Okay. Okay.
Sita, sometimes, no, Prasanna, sometimes it can even stay for about 4 to 6 weeks. So try not to do an antibody titer after you give anti-D, because it will only confuse and the titer will come back as 1:4. Then you are not sure whether it is because of the anti-D that you have given or the patient is isoimmunizing. So try not to do an ICT once you have given an antenatal prophylaxis with anti-D, because sometimes it may linger on for 4 weeks or 6 weeks. So when you repeat an antibody titer after 4 weeks, the titer will come as 1:4. Then you're not sure whether it is the anti-D that you gave or the patient is sensitizing. So better not to do an anti-D levels.
So that's an important point. So if you need to do it at 28 weeks, then give the anti-D. So you'll be sure that she has not gotten isoimmunized in that pregnancy. This question is also related to that. If the mother was given anti-D at 28 weeks, and she does an anti-D, till what titer can this be reported as positive? Is there a titer which you say that this is not because of the antenatal administration of anti-D?
Generally, the titer is 4. Usually, they say that when you give an anti-D, the titer doesn't usually rise beyond 4. And there's another way in which you can differentiate passive versus active, and that's for a blood banker to do, IgM versus IgG. So there are a few ways. They're not perfect, but you could try them out.
Okay. Now, if you have a missed abortion less than 12 weeks, should you give anti-D?
It's better to give unless there is a spontaneous miscarriage. See, below 12 weeks, we think the feto-maternal hemorrhage is less. But whenever you're, instrumenting, you are trying to do with medication, Sita, supposing you need to do a DNC, it is better to give an anti-D. Unless it is just a spontaneous miscarriage less than 12 weeks, most of the things you may have to give an anti-D.
This is to Dr. Prasanna. Do platelets carry any antigen on their surface?
Yes, they do. You have something called human platelet antigens. I don't know what the person was questioning, who was given this question wants to know. But sometimes we were talking, Dr. Nirmala was talking some time back about random donor platelets and single donor platelets. Random donor platelets sometimes could be contaminated with RBCs, in which case you can get RBC antigens. Mainly when you say, do platelets have antigens? Yes, they do. They have human platelet antigens.
No, I think, Prasanna, the question was asked because supposing the patient has had a platelet transfusion for a dengue, will the patient get RH sensitization? That's what they want to know.
Oh, that's a nice question. By and large, platelets manufactured by a blood bank
may have to cover
should be as cellular as possible.
That is because they might carry...
They might have RBCs that carry RBC antigen, to which you could throw up antibodies.
Okay. Okay. It's not because a platelet has antibodies. It's because there might be some RBCs which carry
and that could produce an alloimmunization in your prime or in anybody.
If there are no further questions, I'm extremely happy that this panel discussion went very, very well. It was a very, very useful panel discussion. And I thank all the panelists for giving in their inputs. And I thank Dr. Sita for having conducted such a wonderful panel. And last but not the least, let me thank all the panelists, and let me thank Mr. Subbu and Meenal for having allowed us to do this webinar. And I may say that this panel is having the 1 point. ICOJ has credited 1 point. So all those who listen to this would be getting 1 point. It has been credited. And I thank Mr. Pranag and Mandakari for having given us these credit points. And I'm sure I look forward to working with you all again. Thank you so much.